right. Well, it's really nice to be here with all of you. I'm grateful that you asked, and I'm happy to talk about swallowing and any swallowing questions or concerns that you might have. Um, my understanding is that I know many of you have heard from my colleague, Dory Smith, I believe as well. We work together, and I understand your group is some people who have Parkinson's themselves, family members also with Parkinson's disease. And so my hope is that I can provide you some basic information today, but certainly if there's specific questions you have, I'd be happy to answer those along the line as well. So I have some slides to share, but I can always, stop doing that at some point too if we want to get more into a discussion afterwards. So I was going to screen share if that's okay, just to kind of get us started. Let me find the right thing. Okay. Oh, actually, I forgot to click one button that I thought might help us later. I have a few studies to show. Oh, whoops, also. Sorry. That one. Okay, here we go. Okay, so this is just I wanted to talk about some basic considerations of swallowing and swallowing difficulties, and kind of how we go about evaluating swallowing difficulties and then also treating swallowing difficulties. And my name and what I do is there, but I was going to talk a little bit first about kind of who I am and what I bring from my lens of working with swallowing and swallowing disorders. So I'm on the clinical faculty at the University of Arizona in the Speech, Language, and Hearing Sciences Department. So as clinical faculty is a little different from academic faculty. We all have a clinic where we see patients, and then students join us for our clinics as part of their graduate training. And then I also teach some coursework at the graduate level in our department as well. I teach some swallowing disorders courses and also some courses in medical speech pathology. So what that means is that I'm in a few different places. So I do
hit that. There we go.
So I do my teaching and some clinic work at the University of Arizona in our clinics that are on campus. And the bulk of my clinical work for swallowing is at the Banner University Medical Center in the outpatient building, which is on the North Campus. And Dory Smith and I, as long as our colleague Natalie Monahan, we work out of the ENT group. So if anyone has seen any of the otolaryngologists at Banner, we work out of their offices. And I've been working in medical speech pathology for my whole career, which is getting into the multiple decades now. So I've been in lots of different hospitals across the country and have been involved in dysphagia for all of my career. So I'm happy to talk about that with you today. So just a little bit about me. I'm originally from Lexington, Kentucky.
You fall asleep and drop my phone.
I went to, I stayed there for my whole childhood, and then I went to Northwestern for my training in language pathology, where I stayed for my undergrad and graduate degree at the University of Arizona. So I tend to just survive by just saying "Go Cats" wherever I go, since that applies to all schools and I'm not making preference and I can make everybody happy. So "Go Cats" is the theme for today. So moving to talk a little bit about, I think when you have, when a person is working through Parkinson's disease, there's so many professionals that you are involved in your team. And so in my mind, the role of a speech language pathologist can actually be very broad. I think that, we are people that can assist with swallowing, also speech and voice. So working on speaking clearly and using a strong voice, which I know Dr. Smith has talked to you about. And then sometimes we can offer assistance if other aspects of language and cognition are challenging or problematic, like memory or thinking of words. But for our purposes today, I thought we're just going to focus just on the swallowing piece. So everything I'm talking about today has to do with swallowing and eating and drinking safely and comfortably. So I thought it might be helpful to start with just kind of thinking about what happens when we swallow. Swallowing is something that sometimes we don't think about at all until there's a problem, and then it can become all you think about. But swallowing is actually a very complex activity that we all do. So I wanted to just highlight a little bit about what's supposed to happen so that when we're talking about what's going wrong, we have a comparison. So basically, the purpose of swallowing is to move foods from the mouth all the way into the stomach. That's the whole purpose of that whole mechanism. And it involves structures and muscles throughout the process: lips, cheek, tongue, the hard and soft palate, the throat, the larynx, the esophagus, and even respiratory muscles are involved in swallowing. I think the latest number I've read, which changes slightly all the time, is 23 different sets of muscles are involved in a single swallow. So it's a very complex activity. So this is just to summarize what are some of the steps involved in a normal swallow. So if we're eating something that is solid, it needs to be chewed and broken down into a consistency that the rest of your body can manage. After it's chewed and broken down, your tongue has to work to recollect it, from all the different parts of your mouth, or it might have gone during chewing. Once that food is recollected, the tongue has a very important role in pushing that food from the front of your mouth to the back of your mouth and into the throat. After that, your throat muscles kind of take over. There's several different groups of muscles in your throat whose job it is to keep squeezing basically that food through the throat and into the esophagus. While that is happening, there's a whole other set of muscles that are involved in protecting our airway. As I'll show you in a minute, the two places where food and liquid can go are very, very close to each other. And so it's very easy for things to go down the wrong way. And the word for that is aspiration. So if we see food and liquid going down the wrong way, or we're concerned about that, what you might hear the medical professionals call it is that we're worried about aspiration. And so the whole mechanism is designed to avoid aspiration and efficiently move food to where it's supposed to go. So all of those steps happen usually without us thinking about it, and hundreds of times a day. So if you even feel on your own throat, you can feel some of those mechanisms from the outside. If you just do a saliva swallow, you'll kind of feel some of this step of your throat muscles moving kind of up and forward. Most of us have a real definitive upward movement when we swallow, and you can kind of feel that even from the outside. And our body even knows to swallow differently depending on what we're eating and drinking without us thinking about it. So we tend to produce a faster swallow when we're swallowing a liquid because our body knows that it needs to move a little quicker. We tend to swallow with more strength without thinking about it if we're swallowing a food that's thicker or a larger bite. So it's a very adaptable mechanism that is designed to protect itself. The whole system is designed to protect our airway. So I wanted to point out just a few of the structures that I've been talking about here. So this is the view, obviously, from your head and neck from the side, and a speech
showing
problem.
Pictures.
Pardon me?
It's not on speaker.
Can you all hear me okay? Oh, okay.
No. Can't hear.
So these are some of the structures that we're talking about with swallowing. So we have our lips, whose job is to keep food and liquid inside the mouth when we're managing it. We have our teeth here, which they're responsible, obviously, for kind of breaking food down. The tongue is surprisingly larger than we realize sometimes. There's a large part of your tongue that you can see, but there's a large part that you can't see that goes all the way back into your throat. And then we have the roof of our mouth, which is called the hard palate. And then this little muscle, the thing that kind of hangs back in the back of your throat, is part of your soft palate. So then as we move into the throat, we have, again, the tongue here, the base of tongue here. All along this back wall are muscles in the throat that are together with the tongue help push the food through the throat. And then this whole area here is our airway. This area here is the esophagus. So you can see how they're just right close to each other. And at rest, there's basically an open door between those two parts of our body. When we swallow, the airway here moves up and forward, and the epiglottis covers it. I kind of think of it as like children when they do back in the day hurricane drills, you duck and cover. That's kind of what your larynx does when we swallow. It moves out of the way and covers, there's a cover on it, so to help protect things from going down the wrong way. So in a normal swallow, what we're hoping to see is that things go into the mouth. Your tongue is chewing and managing it very well. It's pushing the food into the throat, and then the food is pushed into this part of your body here. What we don't want to see is that some things are coming forward, which means you're aspirating, or that a lot of food is left over in the throat after the swallow. So those are the things that we're primarily concerned with if those are happening. So then I wanted to show you a video of a normal swallow. So this is an image from a test. Maybe some of you have had this test perhaps, but if we wanted, I'll talk about this more later, but if we wanted to look at swallowing and as a full evaluation, this is one of the tests that we might recommend. So I'm going to get it into a view that we can see well, and then point out some of those same structures that I was just pointing out in the previous slide, which might be a little harder to see in X-ray. But here we have this person's lips. The black material is actually what the person is swallowing. During this particular swallow test, food and liquid is mixed with barium so that it shows up well. This, I'm losing my mouse, is the epiglottis here, that cover that goes over the top of the airway. The tongue is this right here that goes all the way back into the throat. And this is the entrance to the airway this way and the esophagus this way. So I'll let this play maybe even more than once so we can kind of see. So this is a normal swallow, what we're hoping happens. So this person's chewing. The black in the teeth is probably fillings. All the truth comes out during some of these tests. And you can see the tongue is pushing it back, and boom, it pushed it down into the throat. I'll play that one more time so you can see. So it's pretty normal when we're swallowing a solid that we kind of collect it in this one area here until we're ready. And that's what this person's doing now, chewing, kind of pushing, and then boom, there it goes. I see that there's a comment in the chat. Let me look at that. Oh, who cannot hear? Okay. Are there any questions already about anything to do with normal swallowing? I'm happy if you can unmute and ask, or you're welcome to type in the chat as well. All good so far? Okay, good. So then if we're talking about dysphagia, dysphagia is defined really as any disturbance in that process, basically moving the food from the mouth, through the throat, through the esophagus, and into the stomach. So a problem with any aspect of that is called dysphagia. What can get complicated about dysphagia is that different professionals have different expertise and involvement with different aspects of it. So for example, in speech language pathology, we often help diagnose and treat problems in the mouth and throat. So that would be called oral and or pharyngeal swallowing, if the problem is primarily mouth and throat here. Or, but anything beneath that, the esophagus and the stomach, is usually managed by a GI physician. An ear, nose, and throat doctor also is often involved in helping diagnose and manage swallowing difficulties. But again, they're focused mainly on the top part of the process as well. But what happens sometimes is symptoms can be a little vague, and our body's sensory system in this part of ourselves is not as accurate as it is in other parts of our body, what our research has shown us. So a lot of times a person might feel like a swallowing problem is in the throat, But when all the studies are said and done and we have more information, it turns out that problems are a little lower down, and actually it's more of a referred sensation higher up. So sometimes it takes visiting a few professionals to kind of get to the bottom of a problem that might not be as straightforward. So if a person has dysphagia, and we're kind of looking now at the speech language pathology piece of it, that problem could be in the mouth, in which case we'd call it an oral dysphagia. It could be in the throat, in which case we'd call it a pharyngeal dysphagia, or a person could have both problems in the mouth and the throat, and then we call it an oral pharyngeal dysphagia. So some examples of symptoms or difficulties in an oral dysphagia can be these listed here on the left. If a person has weak lips, it can be difficult to keep food in the mouth. If a person's tongue is weak, there can be lots of difficulties associated with that. It can be challenging to chew. It can be challenging to move food back and forth to the teeth. It can be challenging to recollect it and get it all kind of brought back together again. And that pushing action to the back of the throat can be challenging. So those are just some symptoms of oral dysphagia. And again, a few different things can happen in pharyngeal dysphagia. So sometimes that swallow might be a little delayed, in which case food or liquid has a chance to be aspirated before you swallow. So there can be just some slow movements. Sometimes the throat muscles themselves can just be weak. Those muscles can get weak just like any other muscle in your body can get weak. And so that pushing motion through the throat might be not as effective. And so food gets left over in the throat. And then sometimes the muscles that are responsible for closing the airway aren't as strong. And so things go down the wrong way, resulting in aspiration. So I would say when it comes to swallowing, if you're seeing difficulties with muscles in one part of the body, some of those similar difficulties can occur with swallowing too. So for example, if a person is noticing generalized muscle weakness with legs or with walking, or even with the projection of voice, sometimes there's weakness with the swallow too, but since it's not as visible, it can be a little harder to pick up on those symptoms sometimes. So these are common symptoms. Like when I'm working with a person and I ask them, tell me about your swallowing problems, these are some of the answers that I might get. And so I'll just kind of let you read those and see if, so that might be what someone's experiencing when they're describing their problems. Okay. So when a person has dysphagia, and we're trying to determine kind of diagnosing it and determining the severity of it, often as a speech pathologist, I'm looking at two big categories of things. They're both very important. So number one is a swallow safe. Is a person swallowing and protecting their airway and staying safe? Are we worried about choking, airway obstruction, someone needing a Heimlich? Are we worried about aspiration into the lungs? One of the things we get concerned about with aspiration is that sometimes if a person is frequently aspirating, meaning, we all aspirate sometimes, right? Even all of us do. So we get mistimed or miscoordinated. All of us have experienced aspiration. If it's happening regularly and a few other factors to do with your health and well-being are affected, what medical professionals get concerned about is a risk of foreign things now going towards your lungs that don't belong there. And it can sometimes lead to an infection risk like pneumonias. So all of that falls under the category of safety, choking, aspiration, and risk for potentially pneumonia. But a person could have no aspiration, but still have some dysphagia if efficiency is affected. So efficiency, is looking at, is a person able to eat all sorts of different foods with a reasonable amount of effort so that their nutrition is good, their weight stays good, they're eating enough variety. So if someone's swallowing is weak enough that they can really only manage, like, say, I'll pick a more extreme case of someone who maybe can only manage like really thin pureed foods, that everything else is just so thick. What we worry about is, even if they're not aspirating that, is there enough variety there that they're nutritionally sound? So all of that is under the umbrella of what's being considered. Sometimes doctors, the medical, get very concerned with aspiration, almost that they're kind of laser focused on that. And as important as that is, this other piece is really equally as important, also for health, but also to just enjoyment of food. And the ability to, enjoy eating, to still find eating a pleasurable experience. So I wanted to show a few videos. I'm hoping this one loads. It's a little bit, there we go. So I'm going to show some examples of a normal swallow again, and then an example of aspiration on this video. And I'll let it play a few times. So this is from a YouTube site of a professor that has posted a lot of nice swallow studies. So I'm going to play it first. What you'll see happening on the left is another normal swallow. And then the one on the right will show aspiration. So before I play it, just real quick, I'll point out some of the structures again to orient you, but we have the mouth here, the tongue kind of going all the way from the mouth and into the throat. We have the epiglottis here, the entrance to the airway here, and where we want food and liquid to go, which is here. Okay, so I'll go ahead and play. So one swallow, very efficient, nothing going the wrong way. And this is the aspiration video where, oops, I didn't mean to do that. But what you're seeing, and I'll let it finish up, but there's material going towards the esophagus, but a good amount has also gone down the wrong way to go towards the airway too. So let me play that again, just so you can kind of see it one more time. Okay, so that's a safety issue. That's a pretty significant amount of aspiration. And the other thing we might take note of is that most of us, when we aspirate, produce a pretty strong cough to expel what we've aspirated. And in that particular case, it looked like the person maybe was trying to cough, but the cough wasn't quite strong enough to actually clear it out of the airway. So now I'm going to play an example of a person who doesn't have aspiration issues, but I think you'll appreciate how that there's some inefficiency. This is an older video, but again, you can kind of see the tongue is moving already a little bit. They're getting situated. And I'll point out what you're seeing here are some little tremors in the tongue. So this person has a tongue that has some tremors and some abnormal movements just at rest. And then they're getting a little bit of something. This looks like a liquid to me, or maybe a thickened liquid. And it's just kind of sitting on the tongue. Since the tongue is trembling and has some abnormal movements, the tongue can't do that push to the back of the throat. It's just kind of sitting there. And since it can't get pushed back, it can't get swallowed. It needs to kind of get to the throat in order to be able to do anything with it. And they're just getting a little bit down to the very top of the throat. You're feeling like a swallow is about to happen. The hands are probably saying, I feel like it's there, but then they're not quite able to push it down. And it kind of is coming back up into the mouth now. Okay, so this is a case where this person isn't aspirating. So if that's all you're looking for, you'll think all is good, but it's certainly a challenging swallow. I mean, how far into this video are we? We're 2 minutes in and we haven't yet produced a swallow. So I think here you can probably appreciate that it would be hard for a person with this kind of difficulty to really meet nutritional needs and, get all that they need within a day. All right, I'll pause there for a minute and just see if anyone has any questions. And again, feel free to unmute and ask, or if you want to type in the chat, I have that open as well. Okay, all still good? Good. Okay. Okay, so then if a person has dysphagia and we're worried about it being an oral or pharyngeal dysphagia, and you get referred to a speech language pathologist like me, there might be a full evaluation might include any or sometimes all of these three things: a clinical assessment, and then there's two types of what I might call instrumental assessments, where we're using instruments to evaluate your swallow. And I'm going to talk about each of those in just a minute too. So I'll kind of take you through how we look at swallowing and how we might diagnose or determine if a person's having a problem. So if you were to come as an outpatient, to someone like me or another speech pathologist in the community, we'd probably start with a clinical assessment. This is usually done in an office setting. If you're in the hospital, it might be done at your side of bed. If a person's at home, there are home health agencies, but this is, can occur anywhere. And basically it includes sort of a lot of preliminary understanding of a person's difficulties. So usually you're getting a very thorough case history and an interview. Tell me about what symptoms you're having. What kinds of foods and liquids are challenging? Are you experiencing these symptoms all the time? Any difference during time of day or time of meal? Certain foods harder than others? We're trying to get a real pattern of a person's symptoms to kind of fill in some of our questions. A very thorough cranial nerve exam where we're looking at how the muscles in your mouth and face are moving and working. We look at, the lips and the tongue, what's range of motion like, what's strength like. We're looking for, signs there that are challenging. We might watch a person eat and drink with food and liquid. And then sometimes we might do some trial, treatment just to kind of hypothesize, well, if we do this, does this help your symptoms? Do we do this if this helps your symptoms? But nearly always, if a person is experiencing symptoms, particularly in the throat, we can't see the throat by just watching you eat. We can certainly suspect what might be happening. And we can suspect that there's something wrong, but anything beyond that is kind of guessing. Even coughing, people think if you coughed, you clearly aspirated. Not always. Sometimes people cough in response to residue. Sometimes people cough even with temperatures or taste kind of triggers a cough. So if you really want to determine what's happening inside the throat, then you would need to do some kind of instrumental assessment. And that's kind of what we're determining after this clinical piece. Do I need further testing? Is this person have just oral phase problems, which I can see, or am I worried about the throat as well? If I need more evaluation, which one is best? I'd equate this to if you think you broke an arm and you go see a doctor and they don't just automatically send you for an x-ray. They first want to get the whole story. What happened? How did it happen? How long have you been in pain? And then maybe a CT scan is better than an x-ray is better, so they're determining what's the best. That's a similar model to what we're doing here. But I would say, Very often, if we're in the context of Parkinson's disease, it's can be common to have swallowing difficulties in the throat. And so an instrumental assessment is frequently recommended. And so the purpose in an instrumental assessment is to do just that. The two types that I'm going to talk about today both allow us to see inside the throat when a person is swallowing. So we don't have to guess at what's happening. If they're aspirating, we can see it. If there's residue, we can see it. But then we can also try to see, can we prevent that from happening? If I teach you a strategy or modify what you're eating and drinking a little bit, can we make it a little bit easier and safer and more comfortable? So what it does is it shows us which muscles are involved, what's going wrong, and can I fix it? Are there exercises? Are there strategies? Is there something I can do to help? So there's two kinds of instrumental assessments that a speech language pathologist might do. One is called a video fluoroscopic swallow study. That's actually the ones that we've seen so far, kind of the movie X-ray. Unfortunately, I don't know what our field did wrong, but this study is called about 5 different things. So it's a little frustrating if you're receiving it or having an order placed for it. Each hospital might call it something a little different. These are some of the names that you might hear it called for. I think most common is a modified barium swallow study, but hospitals can call it different things. The key is that this is a study done by a speech language pathologist, whereas what it's often mistaken for is something with a GI physician. So that's one type of study. Another type of study is called a FEES, F-E-E-S, which stands for fiber optic endoscopic evaluation of swallowing. So I'm going to talk about each of these because I think, it might be something that's recommended at some point. So I'm going to talk first about a video swallow study. A video swallow study takes place in the radiology department of a hospital. So that's not in an office setting, and you're going to a radiology department. It's an outpatient procedure. It's very quick. It's probably only about 20 minutes, 20 to 30 minutes when all is said and done. For this study, both a speech pathologist and a radiologist is present. The radiologist is running the fluoroscopy equipment and actually pressing the button to record everything, to do the radiation procedure, and then looking for structural problems that would be within their scope. The speech language pathologist is looking at your actual mechanisms of swallowing and helping to determine that. It's very common that you are given a sort of a protocol of different foods and liquids that are different amounts and consistencies. So you might start with a thin liquid that's like water, and then get gradually larger sips. You might do a thicker liquid that's kind of like a milkshake, and then gradually bigger sips, a pudding, and a cracker. All of the material either is made of or is mixed with barium, and that's what allows us to see it on the X-ray machine. And then the machine is pointed to get that view of your head and neck, and it's taking a bunch of little pictures like a cartoon so that they eventually become like a movie. And this is just some pictures of what the setup looks like if you ever go to have this test. This is me actually in our setup at Banner. And then it shows you how kind of the setups can be a little different. This person has more of a portable tube that they're using. Both of these are very common setups here. You can, there's almost always a screen that's showing the study live to everyone in the room. So if you are having this study done, you can see it in real time yourself as well. And then you have the results right away. And we kind of talk about it after the end of the test to kind of talk about what we're seeing and what the recommendations are. Okay, a FEES. So again, that's fiber optic endoscopic evaluation of swallowing. That usually occurs in a doctor's office. We do them here at the Banner ENT clinic. Sometime if you're in a hospital, a speech language pathologist might bring a FEES cart and scope to your room and do one right at the side of the bed. There's also some mobile FEES companies where they bring equipments into skilled nursing facilities and things like that. So how this test works is if anyone has been to an ear, nose, and throat doctor and received a scope, this is very similar. We use the same scope. It's a thin scope with a camera and a light at the end, and it's inserted very gently through your nose and then advanced until we can see your throat. So we see just the top part of your throat, and I have some images to show you as well. While that camera is in place, we first do some speech and voice tasks just to see how things are moving normally. And then we give different food and liquid items with the camera there so we can see what's happening. And it's very common with this test. It's normal food. If nothing is added to it like barium, but it's common to add a colored dye to make the food easy to see. So that's often what is happening during a FEES. And this are some images of people getting FEES. These are both more mobile kinds of situations. This person looks like they're in a skilled nursing center maybe, or even a nursing home, retirement home. This also looks like a portable setting. If you come to our ENT office, we have kind of a tower and you're in an exam chair, but the person has the scope here. Again, a camera is playing what's happening, and then the person, and again, you can eat and drink just regular food. So that's what happens during a FEES. Basically, which test to choose, often either one is going to answer your questions. So either one will provide some helpful information, both about aspiration and about residue. There may be some times that you and your speech language pathologist might choose one or the other. You might choose a video over a FEES if you really want to see the mouth and the throat and the esophagus, all of them, and how food and liquid how those phases of the swallow are interacting with each other. With the FEES, you can really only see the throat. So if you wanted to see mouth and throat, the video gives you views of both. Or if you're concerned that a person might tolerate the scope, usually I can probably count on one hand the number of times, and I've been doing FEES for years, that a person hasn't tolerated a scope. What you do want, however, is if someone is so uncomfortable that they can't swallow normally, then you're not getting an accurate picture, right? So if I'm scoping you and you're kind of sitting there and like this and cringing, I'm not getting a normal swallow. So at some point, you might decide to do one test over the other if you're worried about that. But I will say I've done FEES many times, and it's very rare that we can't get a really nice normal eating experience. So those are reasons you might choose a video. A FEES can be very helpful for a few reasons. One is if you really want to get a good look at the vocal cords. It's very common, and as I'm sure Dr. Smith mentioned to you, but a person might have both voice and swallowing problems. And so this is not the same kind of image you'll get from a voice evaluation, but it can at least give you a little bit of a look at the vocal cords. Sometimes a person's complaining of difficulty swallowing even saliva. And so in a FEES, you can see the saliva and the secretions, which you can't see on a video because they don't have barium in them. Another advantage of the FEES is that we can make it last for as long as we need to answer questions. So in a video, since it is a radiology procedure and there's radiation involved, usually you're limited. You try to turn the machine off and you're not giving quite as many bites and sips. But if FEES, you can just keep going. You can make the study last as long as you need to using real food, which sometimes captures someone's symptoms a little bit more. You might also choose a FEES if a person you feel like sometimes barium people don't enjoy. Some people get actually aversive to tastes and textures that are unusual. And I use FEES quite a bit for biofeedback. Sometimes a person has difficulties with swallowing that they can't feel. And so if there's an image happening, I can say, look, do you see that, stuff in your throat? That's still food. If you feel that, it's good to swallow. So those are some reasons you might pick one over the other, but often either is a great test if you're struggling. So I'm going to stop sharing for just a minute, just to see if anyone has questions or wants to talk about anything that we've covered so far. I'll pull up the chat here.
Kathleen, I have a question.
Yeah.
I remember reading probably, or maybe in another Zoom, I heard that everybody aspirates, but people with Parkinson's have more bacteria in their mouths, and so they're more apt to get pneumonia when they aspirate.
Yeah, I'm so glad you asked that question because it's a really good look at, it brings up an interesting discussion that when we are, so the reason we worry about aspiration is a concern for pneumonia. But what we've learned over the years is that there's many people who chronically aspirate and never get pneumonia. And then there's some people who aspirate not as much or as frequently and frequently get pneumonia. So there is some really nice research out there to kind of guide our thinking that looked at who is getting pneumonia. And there have been some really good studies that have examined long-term people who aspirate. So looking at people who've aspirated for a variety of reasons, a lot of different diagnoses, and followed them over time. And then kept data on which of these people are actually getting diagnosed with pneumonia, and then doing some descriptions of, well, what do they have in common? And they found some interesting things. People who are more likely to get pneumonia usually have some other factors. So you mentioned one, which is bacteria in the mouth. So if a person has not very good dental care or oral care, or needs help from other people to take care of their teeth. So if they're dependent on others, that is a higher risk. If a person is overall more physically compromised, so bedridden, needing help, other people feeding them, those were big risk factors. And the third biggest risk factor was multiple medical diagnoses. So big ones were COPD, heart disease, gastrointestinal disease. So those are the factors that seem to make person A more susceptible. You could have two people aspirating the exact same amount, but those are the factors that make one person more likely to actually have a complication from that aspiration. So to get back to your question, I would not empirically say that people with Parkinson's have more bacteria in their mouth. I think it depends on, everyone's an individual. And if something about having Parkinson's disease makes a person not able to keep their mouth clean, then that's the case. So it's not inherently the disease, it's the functional implications of the disease that might make it harder to keep your mouth clean. Or if the disease has meant that you're moving around a lot less, if a person's, like I said, in bed, then that might make you more susceptible. So I wouldn't put a global statement on it as far as the disease itself. I would say, how does the disease affect those factors that are on that list? That's probably a longer answer to your question than you wanted, but but that's a soapbox issue for me. So I'm glad you asked.
Hygiene, good hygiene, oral
Yes.
hygiene is important.
Good oral hygiene is important, whether you do it to yourself or whether you're caring for somebody who can't do it for themselves. Regular dental visits, making sure you're keeping up with the dentist, because what that means is even if you are aspirating a little bit, what you're aspirating is less likely to be pathogenic.
Thank you.
Yeah. Any other questions? Okay, then I will, whoops, I got something on my desktop. I need to undo this one thing. Okay, let me go back to sharing. So what I'm gonna, maybe I could do a quick, we do this for our grad students all the time. a quick trigger warning that I'm going to show you some examples of some FEES studies. So you've already seen some examples of video swallow studies with the X-ray. So I'm going to show you just some examples of a FEES. I didn't know whether to put these in here or not, but I thought maybe a few people are interested. If you don't want to see what the inside of the throat looks like, I would say just avert your eyes for the next 2 minutes and then you won't have to be subjected to them. But if this kind of thing interests you, I did put a few examples of some FEES studies in here. So the first one is a normal study. Okay, so let me just orient you to what you're seeing here. So this is the view inside the throat of the larynx. This is the view when you're doing these scopes. I am as a practitioner, I'm facing you. And so the directions are reversed. So this is the front of your body. This is the back of the body. This is the left of the person that we're looking at. And this is the right of the person that we're looking at. So it's like you're facing somebody. These are the vocal cords. So when we talk about something going down the wrong way, we're talking about it going kind of into this whole area, but specifically aspiration means it's gone underneath between the vocal cords. Where we want food and liquid to go is in this vicinity. Right around here is where the opening to the esophagus is. And at rest, it's closed. You can't see anything. But during a swallow, it gets kind of pulled open by structures in your throat. And that's ultimately where we want food and liquid to go. This is the epiglottis. The little structure I was mentioning kind of covers the airway. It's a little curly Q. And you can't see it so well on this view, but behind the epiglottis is where that part of the tongue goes. So the part of the tongue I was pointing out that goes all the way into the throat is right underneath the epiglottis here. So in a normal swallow, which I'm about to play, you see, sometimes you don't see food and liquid at all at the beginning. Your body swallows before it even hits the throat. But basically food and liquid comes into your throat. By the time it hits this area, kind of towards the back of the tongue, your throat knows it's time to swallow. Something is getting close. On a FEES, at that moment, everything kind of squeezes together and lifts up. And for a second, we can't see anything. It's at that moment where your airway is closed off and everything is kind of squeezed together. So that's called whiteout. It's a good thing. If you have whiteout, it means that you're able to achieve that closure. But then when the swallow returns to rest, what we're hoping is that nothing has gone down the wrong way and that there's not a lot left over in these little pockets. So I'll show you a normal swallow.
I'm going to take a few sips in a row.
So that was a liquid. It's dyed green. And you can see there's just little traces left over. That's the whiteout. But this is very normal to have those little traces.
So dark.
I think next I'm doing a pudding or something.
Yeah, applesauce.
Applesauce. This is me, by the way. We were playing with scopes one day. That's the swallow. Again, nothing. In a normal FEES, that's kind of ideal. We don't see anything between the vocal cords. We don't see anything lingering. So now I'm going to show, this is a person who has Parkinson's disease. I apologize a little for the quality. I was having some technical difficulties that day. But this, so again, to show you just the structures, we have the epiglottis here, the vocal cords here, okay? We have, we can get a better view of the back of the tongue in this area. And I'll go ahead and play this. And that's a liquid. Whoops, I didn't mean to do that. I meant to pause it. So what you can see here, oh, let me play it again. It started at the beginning. Okay, so this is still a very nice swallow, but you can see there's just a little bit more left over in some of these little crevices here, just a little bit. A second swallow kind of cleared that out. So we have another sip coming up. And what happened there, again, I'll go back to show you, but what happened there is a little bit of liquid went down towards the airway before the person swallowed. And so it just touched the vocal cords. And then that's the normal swallow again. Another swallow. So you'll see some liquid kind of fall down and hit this area right there. And this person did a pretty good job of protecting their airway. They closed those vocal cords right off. But that might be an example of getting a little mistimed. And then I think next we have, this is a pudding. Again, it's dyed green. And you can see there's just there's some left over. So that one swallow wasn't enough to kind of clear it. There's a pretty good amount still left kind of in this little pocket at the back of the tongue. Nothing is aspirating, but there's just that little bit left over. So that might point to a little bit of weakness. You're needing a little bit more force to kind of clear that material. That might be an example where there's some exercises that can help strengthen the swallow. So I'm gonna look, there's something in the chat here. Let me just peek at this. How does voice therapy like speak out affect swallowing? So that's an interesting question. I'll stop sharing for just a second. So there was a question of how does voice therapy like speak out affect swallowing? So voice therapy in and of itself, so there's a few programs that address the voice. So Speak Out is one program. LSVT is a similar kind of program that has a similar philosophies. They're slightly different from each other. So those programs aren't working on swallowing specifically, right? Like those are all very voice focused. The general underlying theme is to use, a little bit more amplitude of effort and your voice and your respiratory support, your volume, all those things. There has been some research though that shows that there seem to be some secondary benefits to swallowing, meaning that from a physiologic standpoint, when you're putting more effort into speaking louder, that in doing that, your muscles are getting a little bit more range of motion and they're being used with a little more force. That's how you're developing that louder voice into some ways. That's not the whole picture, but that's a piece of it. And since it's the same mechanism, it's the same airway, that effort becomes a form of exercise. And sometimes you'll see some crossover swallowing improvements as well. Even if you're not directly working on swallowing, sometimes strengthening those muscles for one activity leads to some improvement in the other activity that uses the same muscles. It's sort of like if I'm a runner and I'm trying to get faster. I'm not a runner, so this is probably a bad example for me to use, but let's say I want to be better at hurdles and I'm going to do some exercises like squat presses, exercises for my quads, because that will help me with hurdles. I'm not doing hurdles, but that one exercise uses the same muscle. So you might see some crossover benefit. It's a similar kind of thing. Any other questions? No? Okay, we'll pop on back here then. So after those evaluations, a speech language pathologist, depending on what we discover, a speech language pathologist might suggest a few things. So if things are looking fairly good and safe and efficient, we might say, let's just monitor your symptoms. Monitor your swallowing status and take a look again in another year, or if you're noticing changes. We might recommend, depending on what we're seeing, strategies to use when eating and drinking. I'll have some examples of that in a moment. Modifications to what a person is eating and drinking, and I'll talk about those more in a moment. And sometimes there's exercises that can strengthen the muscles that we use for swallowing. It's also very common we're doing a combination of several of those approaches. So when I to highlight what strategies means, sometimes there's ways you can eat that minimize your symptoms or help prevent the negative consequences of symptoms. So for example, in that fees that we just saw, where a person had some extra food in the throat, it might help to alternate a solid with a liquid so that you're washing that down. Sometimes head positions are helpful. Many people think that, if I tuck my chin down, my swallow will automatically be safer. That is sometimes a really helpful head position for some people. It completely depends on what's happening with an individual swallow, though. Sometimes a chin tuck actually makes things worse. So because of that, you'll see this is individualized, and it's best to kind of have those strategies based on your swallow study so that they're tailored to what's happening when you swallow, not just in general what's possible to happen. Modifications to what a person eats is not usually my first go-to if it can be avoided, just because, you want to be eating as much as possible that's normal for you. But some people might choose to select foods that are a little bit softer or easier to chew if the tongue is weak. You might cut food into smaller pieces so there's less demands on the tongue. Sometimes moistening things with gravy. It's not uncommon that a person's more likely, depending again on what's going on, to aspirate thin liquids, but slightly thicker liquids are a little more comfortable. So some people choose to add thickener to their liquids so that that's an option. And if we are getting into the area of modifying foods and liquids, there is a standard framework that is used to define that. So for example, what does it mean to have thick liquids? What does it mean to have chopped up food? So this is a resource that a lot of, that's available to you. It's also used in many hospitals these days to use a uniform language when we talk about foods and liquids. So that if I say minced and moist, hospital A knows what I mean, rehab facility A knows what I mean, and you at home can look it up too and know what I mean. This is a very helpful website that provides definitions for what all of these food levels are. So if a person is looking in the area of modifying foods and liquids, this is a framework that might be used to help decide that. And then finally, we might do some exercise-based therapy. So again, depending on what's wrong, we might introduce an exercise program that helps strengthen the tongue. There's a variety of exercises that can increase the range of motion or coordination of the muscles. There's also a lot of therapy that works to strengthen cough. So breathing and swallowing and coughing are very interrelated, and sometimes working on that can also help protect somebody's ability to improve somebody's ability to protect their airway. So that's pretty much it along the course of, what's supposed to happen in a normal swallow. What are some symptoms of some swallowing difficulties? How do we evaluate that? And what are some things that we might do? As far as what to do with all this information, I would say one thing I might recommend is to just pay attention to changes. So if you start noticing that something is different about eating and drinking. So that might look like a few different things: coughing a little more frequently with liquids or solids, noticing that meals are taking a longer time, any sorts of choking incidents that are frightening, noticing that you're avoiding foods that used to be easy to manage. Those are all signs and changes, and that's all might be good times to just take a look. And so if a person notices any of those changes, those can be discussed with your physician, and then a physician can put in the appropriate referrals to get things looked at more. I also think that, it's not, it's never a bad time for any of us to think about kind of what we want from eating and drinking. Sometimes when it comes to changes in eating and drinking, some difficult decisions sometimes have to be made. And so sometimes just thinking ahead of that a little bit can make those decisions a little bit less stressful for you and your family members if they have to occur. So, so for example, some people are very adamant, I am not going to modify my diet. I enjoy my food. Even if it's risky, I really want my morning coffee, my afternoon wine, my whatever. I'm going to have it. So that's kind of good to think about ahead of time. Maybe you are willing to, modify foods or thicken some liquids. What are thoughts about feeding tubes and how those fit in? So I think that when a person's ready to start thinking through that and talking about it with your the people that care about you, I think it does just help everyone with that decision-making process, which sometimes can be stressful when it's happening in the moment. So that is pretty much it, but I'm happy again to answer any questions or other discussion points or anything else you want to talk about when it comes to swallowing. I've gone a little over. I don't know how long these normally go.
Kathleen, knowing that people with Parkinson's often have swallowing problems, is it common to get a baseline swallowing test?
Yeah, great
compare?
question. I certainly think it doesn't hurt to get a baseline swallowing test. I mean, one of the things, and I'd be curious if anyone else has perspective about this, but sometimes what I've seen is that it's not uncommon sometimes in a person who's working through Parkinson's disease, that there's problems that they might not necessarily feel. So this might happen if you think of voice. I have worked with many people who, they might not notice their voice is weak or soft, but their loved ones do. And the same thing can sometimes happen with swallowing. Like there's sometimes something with that sensory system that doesn't quite give that same sensory feedback that there could be a little going on, even if you're not experiencing it. So I think sometimes a baseline study can just help with that awareness. And it's always nice to have a comparison. And it's always nice if it's normal to have reassurance, so I certainly think it's not necessary, but I think it can certainly be helpful sometimes.
Does anyone else have a question? Well, then, Kathleen, I would like to thank you for joining us today. And
Yeah, my pleasure. And
filling us
certainly,
in on an important subject.
yeah, and certainly feel free to reach out anytime. We work in our Voice and Swallow clinic here at Banner ENT, and we're happy to provide resources if you need them in the future.
Thank you so much.
Okay. Have a good rest of the day and weekends. Mhm.